Preventing Opioid Harms in Older Adults, Relief Plus Video Training Series, Best Practices for Opioid Safety, Prescribing and Monitoring, Part 1.
I'm Jim Shames. I'm a family practice physician. I'm also the health officer for Jackson County, Oregon. I'm board certified in family medicine as well as addiction medicine. Opioids have been around for thousands of years, and they are excellent at relieving pain, anxiety, discomfort of all sorts. And what's happened recently is it was perceived that we healthcare providers weren't addressing people's pain, treating people's pain, were indifferent to people's pain. And we started using opioids in essentially an unsafe way. We're using them for people that probably weren't appropriate. We're using very high doses. Kind of forgot the lessons of the last couple thousand years around these potentially dangerous drugs. We were led to believe that people who had quote unquote legitimate pain wouldn't get in trouble with their meds, and that if they continue to have pain, despite the fact they're on opioids, that the right solution was a higher dose of opioids. We now know that physical dependence is what really drives a lot of people to need higher and higher doses.
I'm Roger Chow. I'm a professor of medicine at Oregon Health and Science University. I'm a primary care doc. I also direct the Evidence-Based Practice Center at OHSU, and I was one of the lead authors on the 2016 CDC guideline on opioids for chronic pain. So in terms of the increase in opioids, what we've seen is about a quadrupling of the prescribing rates over about a 10-year period from 2000 to 2010. At the same time, we've seen an increase in the number of overdose deaths that parallel that increase in prescribing. And what we see now is that about 15,000 deaths per year are related to prescription opioid overdoses, a number that exceeds the number of motor vehicle accidents. The opioids can vary in terms of how they're delivered. So we have transdermal fentanyl, which can be complicated in terms of its pharmacokinetics. And then we also have opioid agonists like morphine and hydrocodone and oxycodone. We have partial agonists like buprenorphine, where we think that the respiratory depressant effects may plateau, so there may be a potential safety benefit from using something like buprenorphine. And then we have opioid antagonists, things like naltrexone and naloxone, which can reverse the effects of opioids.
Opioid Safety Recommendations.
To solve this problem, and this problem is that we have way too many pills in circulation. We have way too many pills being prescribed. We have too many pills in medicine cabinets. We have too many pills being traded and, in our community. The way to solve that is we have to look at turning the spigot off, which is the prescribers. They've got to prescribe fewer pills. They have to use other mechanisms. They have to keep their patients safe.
I'm Nicole O'Kane, Clinical Director at Health Insight. I'm also a clinical pharmacist, and I have experience in quality improvement and research around opioid safety. As far as scheduling of opioids, it's very individual, and an individual patient, especially an older adult, will need to be managed for their pain in balance with the side effects. Usually short-acting agents have a benefit, especially in older adults, because they stay in their body longer. And also because of a break between medication doses, there may be time for them to get up and move around and have a little bit more activity. The side effects related to constipation as well can be lower if there's time when the patient isn't on the medication.
We like to avoid initiating opioids with the long-acting opioids. This is both in older adults as well as in younger adults. Long-acting opioids in somebody who is opioid naive or is not physically tolerant to the opioids can increase the risk of overdose. And that can be of particular concern in older patients who may be at higher risk for overdose because of medical comorbidities or other medications that they may be on. It's very important to also be aware of whether a patient is on benzodiazepines, which is a commonly used medication in older patients. This can multiply the risk for respiratory depression.
So this is kind of simplistic, but you can think of pain in a couple of categories. There's acute pain. I think we all know what that is. You break a bone, you fall down, you've traumatized yourself, and somehow you've had surgery done. And that pain is mediated by pain fibers. They go to your spinal cord, they go to your brain. They have a definite mechanism. In the case of a broken bone, it's like, don't move that bone, right? And so opioids are very effective for that kind of pain. You usually don't need them for very long. If you had a tooth extracted or something, maybe a day or two. You had hip replacement, maybe 4 or 5 days. The point is that it's very appropriate for opioids, sometimes high-dose opioids if that's what's necessary, to get you through the stage. The point of acute pain treatment is to get you back and active and functional again. The goal is return to function. Chronic pain is actually different. There's no fracture, there's no acute episode, and yet the pain continues. And that pain can be managed, usually learning how to move again and exercise, perhaps learning how to relax and kind of let the pain do what it's going to do and then come to the other side of it. There's lots of strategies for managing chronic pain, but opioids is a dangerous route to go down. Not to say that episodic use of opioids, when that particular cause of pain has flared up and exacerbated, but daily use of opioids can often make chronic pain worse, and it certainly can make chronic pain treatment much more difficult to manage.
Much of the focus around opioid safety in the last few years have been on focusing on people that are already taking opioids, people that are being treated for chronic pain. But it's important to remember that new exposures to opioids are just as important. So the treatment of acute pain and guidelines around acute pain are changing drastically. The CDC guidelines include some clear recommendations, including staying under 50 morphine equivalents and not going above 90 morphine equivalents. And that we've found that many patients were above that dose, and that's where the risk of overdose occurs. In addition to that, the CDC, through evidence, has looked at other increasing cofactors with opioids, one of them being the high dose of opioids, the other being co-prescribing of benzodiazepines, so whenever possible, not using benzodiazepines and opioids together. Another factor that the evidence has shown is that long-acting opioids are actually more dangerous and more associated with overdose. So as much as possible, the recommendation is to use short-acting medications, short-acting opioids, instead of the long-acting agents that were used in the past.
One of the revelations for me is how valuable pharmacists are, how important they are, how well educated they are. And what I hear from them quite frequently is, we have skills, we're trained, we're being underutilized. And I think that's absolutely true. Pharmacists can both educate the patients on their medications. They certainly can educate the providers about safety issues with their medications. And increasingly, pharmacists are playing a role, for example, in drug take-back. We have pharmacists in the state that have lock boxes in the pharmacy. And you can say at the time of prescribing, and when you're done with these pills and you don't need them anymore, you can just put them right in there. So the pharmacies are very important in this.
The pharmacist has all the information about the medication that the patient's taking. A pharmacist may know about a specialist that's prescribing opioids separate from what the primary care prescriber is prescribing, or the pharmacist may know about benzodiazepines that are being prescribed by a specialist that the primary care provider may not know about. Especially in rural areas, a good working relationship between the pharmacy in that town and the prescribers causes improved care for the patient. It causes more coordination. There's additional information that the prescriber can get from the pharmacy. So really important to have a good working relationship with the local pharmacists.
Communication and considerations for tapering.
My name is Michelle Maricos. I am a peer support specialist and person living with chronic pain. So I live with chronic pain, and in 2003, I was 23 years old. I was going to school and looking forward to graduating from college. and I was in an accident. I had an accident and crushed 3 vertebrae in my neck. I had never been prescribed opioids or any kind of pain medication, never had any injuries, didn't have any history of injury, didn't really know what pain looked like or felt like. And so this injury happened and I was prescribed medication, and it was quite a bit of medication. And over 10 years, I was on that medication, stayed on that medication, had a surgery, ended up being prescribed more medication. So in 2012, I was able to go to the Mayo Clinic. And by the time I got to the Mayo Clinic, I didn't realize that I was living with chronic pain. I didn't know that that was an actual thing. I didn't realize that the amount of pain medication that I was on was too much, and that I was living in a fog. So at the Mayo Clinic, they do a pain education program and a taper. So the taper happened, and I was able to do the taper, was able to get off the medication, and got my life back, got my personality back, and it was really great and wonderful, and was able to start my life over again. I will always live with chronic pain, but I live with chronic pain with tools and tips and tricks, and in a very different way. Instead of pain being the enemy, it's now my friend.
There's a perception that patients don't do well with tapers, but there's actually more and more evidence showing that patients who taper often report that their pain is no worse and sometimes better than before they tapered, and that they often are more functional because they're having fewer side effects from the opioids. With the taper, if we taper slow enough, most patients will not have any withdrawal symptoms, but if they do have some symptoms, we can help treat those. And then we need to use all of our other tools to manage their pain. So it's not like we're just stopping the opioids and not doing anything. So that's the other important thing to explain to patients. And so all of our non-opioid medications and all of our non-pharmacological therapies we can use in conjunction with the taper.
So the reality is that because we've been dealing with this condition of inappropriate and overprescribing for decades, every practice has got a significant number of patients who have been passed from provider to provider on high-dose opioids, and they remain on high-dose opioids. And there's various terminology for that. Some people call them our legacy patients or the lost generation, but there are perhaps millions of them, and part of the trick is learning to handle those patients.
Hi, my name is Todd Korthus. I'm Associate Professor of Medicine at Oregon Health and Science University, and I'm also Chief of the Addiction Medicine section there. One of the major clinical challenges that I think all of us face are patients who come into us with very high doses of oxycodone or whatever full opioid agonist prescription opioid. And we put them on our taper plan, and they're coming down and they're coming down, and they get to a certain point and they still just can't go any further. And then the question is what to do. Do you throw in the towel and say, I'm sorry, I just can't prescribe to you anymore? Maybe the patient is ready to throw in the towel because they're not happy with this plan whatsoever. And I encourage providers to really stick with those patients and let them know they're not being abandoned. Let them know that you're going to treat their pain through other pain treatment modalities. And if in the process of coming down on their dose of opioids, we're unmasking an opioid use disorder, or they're having problems with this, it's perfectly legitimate to switch to buprenorphine as an alternative.
Considerations for prescribing opioids for older adults.
My name is Joyce Schoberg, and I am an aging life care manager. My background's nursing, graduated from OHSU, and I own Aging Advisors. It's a local aging life care management company here in the Portland, Vancouver area. Well, when When it comes to nuances with older adults and prescribing narcotics or other pain medication, certainly some of the challenges that we've observed and try and create workarounds for older adults are vision, because the medication often comes to them in bottles that is, the script is just so small. It's very challenging for people to read whatever's on that. Depending on their relationship with their local pharmacist, there's often, hopefully, a good pharmacist that can help with that, and sometimes not. Sometimes our older adults have caregivers or family members that are picking up that medication, and they can hear one thing, just like the telephone game, and by the time they're back in the home, what is relayed to that actual older adult can be a whole nother picture or another story or scenario. And so really getting good information, getting it written down in fonts that they can read and absorb is helpful.
My name is Mary Schiff. I'm a patient advocate, and I'm also a chronic pain patient. You wouldn't know that I can only see out of one eye, and that is a problem for me sometimes, but you wouldn't know that. And a primary care provider may not know that either unless the patient has shared. So I think the patient has to be really comfortable with the physician in order to share their information, but I think the primary care provider has to be astute enough to realize the patient may not be sharing everything and that there are things that are really important that they need to know.
Older adults who have chronic pain but don't have an end-of-life condition, they may be on opioids for many years. The opioids have serious risks, and again, thinking about all of the other psychological and medical comorbidities and polypharmacy involved, it's critical for us to really take a very rigorous look at the opioids to decide whether they're appropriate or not.
I'm Dennis Turk. I'm the John and Emma Benica Chair and Professor of Anesthesiology and Pain Research at the University of Washington. Most research studies, and I'm guilty because I do research, you have exclusion criteria, and most of the exclusion criteria are people over age 65 and people who are taking multiple medications. Well, therefore, if all the studies are done on people under age 65, and now we have people who are over 65, we don't know if these drugs are going to have the same effect. Metabolism is different on people. The way that these drugs are going to be synthesized are going to be different. The dynamics within their bodies are going to be different. So any medication that's good for maybe useful rather than good for younger people, you have to be cautious.
Medication side effects for opioids are diverse, and different people respond differently and have different side effects. So certainly the side effect that we are most concerned about in all people taking opioids is diminished breathing or slow breathing, which certainly can happen in an older adult, especially if they're on other medications that can also diminish their breathing. In addition to that, older adults can have a lot of risk related to fall and balance, and they can also have more risks related to constipation and changes with their digestive tract. They're more sensitive to nausea, and they may also be have a more difficult time explaining that they're experiencing that side effect. In a younger adult, they may be able to tell you that they're feeling dizzy, versus an older adult may not be able to explain that to the provider.
So I think with older adults, it's helpful to kind of remember the natural aging process, which means that there is some degree of decline. And none of us really want to accept that, but it's a reality that would be helpful to keep in mind. And what I mean by that is it's very easy to be prescribing 8, 10, 12, 15 medications for somebody because there's 8, 12, 15 parts of their body that just don't feel right or work right. I think minimizing medications to the essential is really important because these medications can affect people's cognitive ability and ability to remain functional. So there's that in general. The sedating medications like benzodiazepines and opioids have a profound effect on older adults. We need to use them cautiously, episodically, and we need to warn them and warn their caregivers about these potential side effects as well.
It's so important with older adults to look at their whole kind of panorama of medications that are in their home and the multiple medications they are receiving. Many of the older adults that we work with see sometimes 2 or 3 specialists and a few handfuls up to 10 or 12 or 15. And so if all of them are prescribing, it really becomes challenging for the older adult to know whose instructions to follow and to really start to become confused.
Screening tools and monitoring resources.
Assessment of patients with chronic pain on opioids should be multidimensional. So instead of just focusing on pain, we think people should focus on what we call the 4 A's. The first A is analgesia, so that's pain. The second A is ADLs, so activities of daily living or functional status. The next A is adverse events, so any adverse events related to the opioids like effects on constipation, cognition, etc. And the last is risk of abuse and addiction. And so if you think about all those 4, you can have a more complete picture of how the patient is doing on opioids and make more informed decisions about whether it's something that should be continued or whether another approach should be taken.
You need to screen for substance use disorder. You need to screen for depression, for anxiety, for all the coexisting conditions for which there are much better treatments, right? We're back to the basics of medicine. Take a good history, get old records, maybe talk to previous providers, and then go forth.
So sleep apnea is quite common in older adults, and opioids can increase the risk of respiratory depression and hypoxia and may increase the risk of accidental overdose. So it's important to consider sleep apnea before prescribing an opioid. There are simple screeners out there. The one most commonly used is something called the Stop Bang tool, and many primary care docs are familiar with this. You get a score on it and it tells you what the risk of sleep apnea is. Psychiatric comorbidities can impact safety of opioids as well as management of pain. It's important to assess and treat psychiatric disorders in patients, in older patients, and it's important to use that information to help decide whether opioids may be appropriate or not. Again, there are a number of screening tools available for assessment of psychiatric comorbidities, including depression. The most commonly used one is the PHQ-9. There are even shorter versions, including a 2-item PHQ-2, which can help identify people who need further evaluation and assessment. For the opioids in particular, our PDMPs, our prescription drug monitoring programs, can help us to ensure that people are filling the medications and that each refill is lasting an appropriate amount of time, that they're not running out too early or too late.
Opioids kill tens of thousands of people in this country every year. Some of those are prescriptions, some of those are heroin and fentanyl, but the point is that if you're going to prescribe these medications, you have to wrap a safety around it. And that means that every patient that gets opioids needs to be screened. You need to do urine drug screens. If they're on chronic opioids, you need to call them back for pill counts, probably once a year or so. You need to have a registry so you know who they are. This is about safety. I do this for every patient. These are powerful and dangerous drugs. I want to make sure you're safe. I want to make sure that your relatives and friends and the people you associate with are safe. However you have that conversation. I think that's the approach.
Preventing opioid harms in older adults. Visit healthinsight.org/relief-plus for resources related to the topics discussed in this video. This material was prepared by Health Insight, the Medicare Quality Innovation Network / Quality Improvement Organization for Nevada, New Mexico, Oregon, and Utah, under contract with the Centers for Medicare and Medicaid Services, CMS, an agency of the U.S. Department of Health and Human Services. The contents presented do not necessarily reflect CMS policy 11SOW-OSSIP-18-06-OR